Dr. Lowry, tell us, what is a pulmonologist? What do you do?
A pulmonologist is a medical doctor who has gone through an internal medicine residency. And so our specialty is internal medicine, and then we do a subspecialty training. It's called a fellowship in pulmonary medicine. And most of us do 2 fellowships at the same time. So we do pulmonary and critical care. So you'll hear that we're triple boarded, which means internal medicine, pulmonary, and critical care, because most intensive care units are staffed by medical doctors who are pulmonary and intensive care certified. So from the pulmonary standpoint, I take care of people's lungs, and that comprises a long list of oftentimes chronic diseases. That doesn't need to be chronic, but oftentimes we deal in chronic diseases of the lungs.
Now, when we talk about chronic diseases of the lungs, and it could be varied, if you will, some of which may be environmentally caused and others of which may be genetic in nature, are there ways in which you would characterize those different chronic diseases?
Yes, indeed. Whenever we divide up lung diseases, there's a lot of different categories that we can put them in. The ones that you described are definitely very accurate. When I think of lung diseases, I usually think of airways and then lung tissue. So when I think of airways, those are the tubes that guide air in and out of our lung tissue. Their job strictly is to help the lungs communicate air with the environment. So airways diseases can be, you can be born with them, and you can also acquire them on your own. So an example of the kind that you're born with would be asthma. So a patient with asthma has chronic airway inflammation, and that chronic airway inflammation is oftentimes, not always, but oftentimes caused by the same pathways that lead to allergies. So an asthma patient may have sensitivities such as cat or pollen, things that really, when the airways get exposed to them, lead to higher degrees of airway inflammation, swelling, mucus production, itchiness, which is often manifested as coughing, and they can get swollen, which gets manifested as airway obstruction, mild airway obstruction, and that usually occurs as wheezing. So that's an airways disease that one might be born with. An airways disease that one might acquire is COPD, which is also called emphysema. So COPD represents a chronic airway inflammation that's caused by an exogenous substance, which is tobacco smoke. So a lifetime of exposure to tobacco smoke leads to the chronic inflammation in the airways that proceeds on and on and on year over year, and finally ends up with so much airway inflammation that it appears very similar to somebody who might have asthma and having a really bad day. They're just chronically obstructed and inflamed, coughing up lots of mucus, and oftentimes wheezing and short of breath. So those are the airways. And so then we also think of lung tissue diseases. So lung tissue diseases can take many forms, but just as an example, we'll talk about pulmonary fibrosis. So pulmonary fibrosis, as far as we know, doesn't have an obvious cause. Idiopathic means we don't know. So idiopathic pulmonary fibrosis is when the airways look okay, but the lung tissue itself begins to get fibrosed and scarred. So that's an example of pulmonary, what we say pulmonary parenchymal disease, that is not caused by anything as far as we know. Pulmonary parenchymal disease that is caused by something might be something like asbestosis, where we breathe in asbestos in very significant quantities, especially early in life, and that causes a degree of fibrosis and asbestosis in the lungs that looks sometimes a lot like pulmonary fibrosis, but it actually came from the asbestos fibers.
We often hear the term inhalers as an appliance, if you will, that one might use if perhaps they're having an episode with asthma or some other airway obstruction. Yeah. Can you tell us a little bit more about the different types of inhalers that the general population uses over the counter, so to speak?
Absolutely. It's a great question because we love inhalers, and there's a reason, is because they help people. So I think of three broad categories of inhalers. So the first category that I think of would be the short-acting bronchodilators. And that is the one that most people are familiar with. You might call it albuterol, you might call it ProAir, you might call it Ventolin, Proventil, but these are all forms of albuterol. And the main job of albuterol is to open up the airways a little bit. So our airways are very complicated, and they are lined and they're controlled to some extent by smooth muscle, which is muscle that we can't just use, like, for example, our arms and leg muscles. We don't really have control over our bronchial smooth muscle, although the body is controlling it. So the albuterol goes in and it helps the bronchial smooth muscle to relax its tone a little bit, which leads to an opening up of the airways. And it leads to an immediate feeling of relief to somebody, for example, with asthma, who's tight, who's inflamed, and the bronchial smooth muscle is really clamped down. The inhaler helps to release that muscle and to open up and give the asthmatic some relief. So we call it the rescue inhaler. So with an asthmatic, especially asthmatics who are dynamic, which means that they can easily go back and forth at short notice, they get tight or wheezy, we have them take 2 puffs of their ProAir. An asthmatic child, for instance, who plays sports, we often recommend the child take a few puffs of albuterol before they play sports, just to sort of get their airways open and help their asthma get through the game. So that's type number 1. So then type number 2 would be the long-acting version of those medications. So the long-acting version of albuterol is sort of a 24-hour or a 12-hour version of albuterol. We call it different names. It's got different forms. But instead of taking it in the moment that you don't feel good, for example, wheezing or coughing, you take it either once a day or twice a day, so that you're constantly giving those airways exposure to that bronchodilator, so that you may need less ProAir or less albuterol. Another long-acting bronchodilator and airway stabilizer are what we call the anticholinergics. So this would be like a Spiriva or Incruz, and those drugs act on a different part of the airway, so that they're similar to the albuterol, but they're in a different part of the airway, allowing for the airway to have a longer term of stability and to not be as tight and clamped down. And those medications tend to work and were designed for COPD patients, although we're starting to use them more often for asthmatic patients. And then finally, we have the inhaled steroids. So those are a big category of medication that we really didn't have decades ago, that have really led to a revolution in treating asthma. Because what these folks really need is they need less inflammation, they need less allergic inflammation in their airways, and the inhaled steroids go right to where that inflammation is. And over the period of weeks, months, sometimes years, with daily use or twice daily use, the inhaled steroids can really reverse the airway inflammation and lead to much more stable airways that are much less susceptible to things like allergens or the cat dander or the ragweeds that are out there, because over time we've really settled those airways down with the inhaled steroids. So 10 years ago, we used to think, well, the inhaled steroids are more for asthmatics, and the Spiriva and Incruz, the tiotropium, the anticholinergic inhalers, were more for COPD patients. But there's been a lot more crossover. lately, and we're starting to use all those medications for both categories.
Dr. Lowry, we're obviously in a pandemic, and I'm curious about patients and how they may avail themselves of your services, the services of a pulmonologist, using telemed as an example. Can you share with us what some of those experiences using telemed might look like, work like for those patients?
Yeah, so we're using telemedicine for everything that we can now. We've learned so much from this pandemic about what the power of telemedicine is and how much with good technology, we can do almost what we can do in the office setting, but the technology has to be there. So I can see a new patient, I can talk through the symptoms, I can look at all the imaging, I can think of tests to do next in order to narrow the diagnosis, then do a follow-up where we review the results of those tests, and then initiate the proper therapy. And we can do that all by telemedicine. We lose the advantage of a face-to-face encounter. We lose the advantage of physical examination. That's a big loss, but with all that's going on out there, we really push hard to take advantage and leverage that. So my Fridays are spent in large part doing telemedicine visits. Often new patients I'm seeing for the first time. If there's something I need to see, I order it. So if we need to check out the heart, I order an echocardiogram. If we need to look at the lungs further, we'll get a CAT scan. We can get where we need to be through telemedicine and get the care in the patient's homes where it really needs to be.
What do you anticipate with patients who are COVID-19 survivors and the impact on their lungs?
So a measurable number of those folks are going to have long-term symptoms. We know this already. Long-term, I mean, we've only had COVID now for a year, so that's long-term in terms of COVID-19. But we do know that there's a group of patients who had COVID who are falling into what we call the long hauler category, who have protracted symptoms. And these are serious symptoms. These are folks who really need a lot of medical attention. They have persistent shortness of breath, they have persistent cough, they might have other less related symptoms such as cognitive slowing, depression, in some cases psychosis, in some cases topical symptoms like hair loss, dermatologic changes. We don't know all the things yet. So in my clinic, I'm seeing folks who had COVID, who are coming in with persistent shortness of breath, persistent cough, persistent constitutional symptoms such as exhaustion, cognitive slowing, sometimes depression. So these are really serious. The very first thing I do with these folks is to say, listen, this is real. You're not malingering. You're not sort of absenting yourself from the usual recovery process. This is serious business, and we have to follow you folks closely. The downside is we don't have a lot of great drugs or therapies, although we are starting to learn a lot more about it. I'm focusing my therapies on the symptoms at hand. So cough and shortness of breath, I'll start some inhalers. I'll get some basic testing to see how the lungs are, and then go from there. But sometimes, these folks are confused because there's so much going on with COVID right now. Some of these folks are sort of getting kind of lost only because they're better. And so we have to focus on the folks who are not better or in the hospital. So they don't necessarily get the full attention. So I try really hard, full attention for an hour, and sort of listen and learn and try to understand what their main symptoms are. COVID is such a broadly morbid virus. It affects the lungs, it affects the airways, it affects the lung tissue. You get a severe pneumonitis, And then that's week 1. So that's more of a typical viral pneumonitis, you might say. And then week 2, it tends to become a much more involved and morbid illness that tends to be more endovascular, the small vessel spaces in the lungs causing thromboembolus, blood clots that are on the microscopic scale in the lungs, the kidneys, and elsewhere. And the folks who really do poorly from COVID generally do poorly in the second week when that bad endovascular process gets going. And the folks that survive that, we know that it's survivable because there are folks who do survive it. What they're going to look like 1, 2, 3, 4, 5 years down the line, we don't know, but we do know we have to take really good care of them and keep track of them in the clinic, because as soon as good therapies come out, we want to be there.
I read last year, I believe it was, the CDC came out with an advisory about vaping and COVID. And it was stated that those who are actively vaping are 5 to 7 times more at risk of catching COVID. What are your thoughts about that, Dr. Lowry?
So I haven't seen that, but I would be happy to review it. So the thing with vaping and any inhalation, we put our lungs at risk. You know, with the lungs are so precious and so delicate. I swear, if we could all see what the lungs looked like, not just sort of in the jar of formaldehyde, but under the microscope and up close, what separates us in the lungs, what separates us from air, is really just 3 cells. One is the endovascular cell, which is the cell that lines the blood vessel in the alveolus. Then there's the mesenchymal cell, which sort of provides the structural support. And then there's the alveolar cell that lines the airways, and that's it. It's just those 3 cells, and it has to be that thin because we need gas to be able to diffuse across that cellular membrane. If it was too thick, we wouldn't be able to diffuse oxygen and carbon dioxide. So it needs to be that thin, but it's very delicate and it's super susceptible to insult and inflammation. And so vaping and cigarette smoke and any particulate smoke that can get as far as that alveolar sac just carries with it so much risk. Vaping is just a way to make the particles so small that they can get down into that gas space and diffuse into our bloodstream. That's the reason that vaping, was developed. Same thing for cigarette smoke. You got to get the particle small enough to get into that alveolar space and diffuse. So, who's making the vaping oil? We don't know. It could be from somebody's basement. It could be from a lab somewhere. It could be a high level of pharmaceutical. You have no idea what's in it. Could be heavy metal, could be toxic, could be baby oil added as a filler. You just don't know. And all of it's bad for you. So I'm not surprised that folks who have really put that 3-cell barrier at risk are at higher risk for those infectious diseases, simply because it breaks down that natural mechanical barrier. You shouldn't vape. For a very short period of time, we were thinking, maybe vape, e-cigarettes were going to help folks stop smoking. And there was even a lot of epidemiologic study and talk about saying, well, we know vaping is bad for you, but is it worse than smoking? Because that's a credible question. Like, if we lose 10 people to vaping and 10,000 people to smoking, should we really tell people not to vape? But the bottom line is, we don't know. We don't know how harmful it is, so we can't really say that it's less harmful than smoking. I don't advocate vaping or e-cigarettes to help quit smoking. There's better ways to quit, and there are more stable ways to quit to bring yourself to a healthier life than vaping.
Dr. Lowry, in the remaining time that we have, to the listener watching and listening to you in this moment, What is it that you want them to take away, the message you want them to take away about your work in pulmonary medicine?
Okay, so my work in pulmonary medicine, a lot of folks who come to me and present to me are driven by symptoms. And so that's a common language that doctors and patients have. Patients know symptoms. Doctors are trained to sort of work within symptom patterns. So be on the lookout for symptoms. You can't be too worried. For example, here's a good example. In COVID isolation, we've all become less active. I know I have, probably everybody has. Some of us are trying to get back out there and reclaim it. The first symptom we get is shortness of breath. We try to run or jog, perhaps a mile, you might get short of breath. Well, that's gonna happen. So shortness of breath is a symptom that has a range of what is expected, and then it has a range of, like, this needs to be seen by a doctor. So if you've been inactive for a year and you go out and you get a little bit short of breath, that's to be expected. If you get chest pain, or if you get dizzy, or if you get to the point where you can't speak because of your shortness of breath, that's a red flag symptom. So that's the kind of symptom that needs to come in and see somebody like myself. Similarly, everybody gets colds and flus. Do you need to see a doctor with every cold? No, you do not. And you're gonna have a cough, you might even cough up a little bit of sputum. That's to be expected. Whereas if you're coughing up sputum and the sputum is changing color, or it's becoming foul, or it just won't quit, and you're up all night with coughing and you're starting to feel like this may be something more than that, then it's time to see a doctor, because we need to do chest x-rays and we need to check you out for something more severe like pneumonia. And honestly, we love taking care of folks, and that includes folks who are really sick and folks who are not very sick. So if you have a concern or a question, you're always welcome to contact us. We'll see you right away. And a certain bit of our day is just making sure that you're good and you're good at health, and that's great news for you and great news for us. So we're happy to see anybody.